Welcome to RUMC Connections. Welcome to RUMC Connections. I'm your host, Meredith Gaskins. On previous episodes of RUMC Connections, we've talked about the importance of recognizing medical emergencies early and knowing where to turn for expert care. So today's conversation is slightly different. Today we're talking about something that affects every single one of us, aging, and more importantly, how to do it well. So most people think aging is about treating one condition at a time. But what if the real risk isn't any one disease, it's how everything interacts? We're joined today by Dr. Gottesman, who is leading a brand new geriatric care program right here on Staten Island at Richmond University Medical Center's newest site, the new Springville Center for Family Health and Specialty Services, located at the Staten Island Mall. So welcome. Thank you so much for joining me today.
Thank you for having me.
Of course. So as people age, they are not just dealing with one issue. It's often a combination of chronic conditions, changes in mobility and cognition, and evolving social and emotional needs. So today we're breaking down what a geriatrician actually does, how it's different from a primary care physician, and how to know when it's time for you or a loved one to see one. So just to give everyone a little background, Dr. Gottesman graduated from Queens College, CUNY, cum laude, with a bachelor's degree in history and a minor in Jewish studies. He earned his Doctor of Medicine from Albert Einstein College of Medicine in the Bronx and completed both his residency and chief residency in internal medicine right here on Staten Island. He served on the leadership committee of the Society of Hospital Medicine and is a senior fellow of the society. He's also a fellow of the American College of Physicians and a member of the American Geriatric Society. So beyond medicine, he's deeply involved in the community, serving on the board of the Rabbi Jacob Joseph School of Staten Island and volunteering with the Hebrew Free Burial Association at Mount Richard Cemetery. So let's start simple. Maybe you could break down exactly what a geriatrician is.
Sure. A geriatrician is a physician who takes care of people who are aging. Their focus is not so much on the medical problems exclusively, like a traditional physician, as much as understanding the medical problems in the greater context of the patient's life, their value system, and their family and support structure.
Okay. Perfect. So how would you say geriatric care maybe is different from the care that someone might get from their primary care doctor?
I would say that the care provided by a geriatrician is different from that provided by a primary care doctor, and that a primary care doctor, number one, usually has less time. A primary care doctor is generally focused on the problems, the medical problems specifically that patients present with, looking for quick solutions, usually in the form of medications and prescriptions. A geriatrician is not looking just at the medical problems. We don't view patients as just a list of problems. We look at patients as human beings who happen to have medical conditions. So we look at the way those medical conditions affect the patient's total quality of life, the way it affects their functional ability, and we try to focus on their joy, their happiness, and what their value systems are and how their medical conditions may tie into or have an impact on their quality of life.
Okay. So why does aging require a different approach to medicine, do you think?
Aging requires a different approach to medicine because medicine traditionally is focusing just on what we call the pathology, the organ system problem. What's wrong with your heart? What's wrong with your thyroid? What's wrong with your stomach? What's wrong with the different parts or organs, or organ systems in your body? As our bodies age, our bodies change. The way we react to medications may change as we grow older. The way the medications are metabolized or broken down in our bodies may change. And what the impact or side effects of medications are can change as well. And how we react to the medications, which when we were younger may have been tolerated well, can change dramatically as we age.
Wow. Yeah, I could understand that. I'm sure even the difference between a year or two could make a big difference in a medication, how it's affecting a patient, and if other symptoms, are presenting themselves, that it would make a big difference.
Yeah, medications really are a critical component of what we address and what we focus on. But medications can be a hindrance, and they can be a help, and they can be the source of the problem in the first place. And I hope to address that a little bit later in this podcast.
Definitely. Okay. So what would you say maybe are some misconceptions that people might have about geriatricians?
Yeah, I think misconceptions that individuals and people as a whole may have about geriatricians is that geriatricians take care of the old, the very old, the sick, the very sick, patients in nursing homes, for example, who may be bedbound, patients who are so far gone in their aging process that we're kind of taking care of patients who are no longer functional in society, patients who, to a large extent, are super old. We really take care of patients of a wide range of ages. There's no specific age in which a geriatrician gets involved in care, although traditionally we usually use the number of 65. So 65 is the usual number that's used by society to distinguish people who are working or not working or think of in terms of retirement. But we really take care of patients who are at the cusp of perhaps leaving the workforce, thinking of transitioning from their younger years into a new phase in life, and view that really as a point in time where they need to reassess their values, their financial structure, what their goals and values are in their life.
Okay, that makes sense. So it's not just about treating more conditions, it's something else entirely, right?
Absolutely. Geriatrics is not about treating more conditions. It's not simply a pile of medical conditions that just accrue or accumulate, and more things go wrong in your body. More and more problems seem to accumulate, and the list of medical problems just gets longer and longer. It really is looking at the medical problems as one component of what we assess, but it's also looking at functional ability, quality of life. Are you aging gracefully? Are patients aging into their so-called golden years intact, in good health, with their value systems, with their social support? And how does their life as a whole really play into how they view themselves, gives them a sense of self-esteem and satisfaction, a sense of complacency, and a sense of waking up in the morning with a spirit of joy and excitement.
Perfect. Okay. Now, I know that you use a framework called the 5 M's, which I think is a great way to simplify something that could really feel complex. So could you maybe walk us through those and in a way that listeners could understand?
Sure. So the 5 M's is a classic geriatric assessment model that describes the 5 categories that a geriatrician will evaluate and assess in a classic geriatric visit and assessment. M number 1 stands for mind. We will assess a patient's cognitive abilities and their assessment, review their mental status to ensure that they may not be suffering from depression or other issues which may affect their thinking ability, their mood. That's what the first M stands for, mind. The second M stands for medications. We will do a comprehensive medication review. We'll assess whether the medications patients may be on are all necessary and appropriate. Frequently, patients present on medications that they've been on for decades, and no one's ever bothered to say you no longer need this because it's been on their list of medications for so long. It hasn't been questioned as to whether the medications are still even necessary or they're still suffering from the condition that they may have been originally suffering from, for which they were prescribed that medication. We will also do a review of medication side effects, since medication side effects are a frequent cause of problems in the elderly. We will also do a mobility assessment, assess patients' functional ability. How are they walking? Are there issues with their gait? Are there issues with their footwear? Are there issues with their shoes or any other aspect which may impair their mobility? Are there subtle signs that their mobility is starting to cause issues with their functional ability and their ability to have a higher quality of life? We will also look at very important M number 4, which is what matters most. Starting to really think about value systems, think about what determines patients' quality of life, what determines what matters most to the patient in their current point in life, where do they see themselves, what will matter in 5 or 10 years, how do those values really interplay with their family structure, their religious and cultural beliefs and background and values, and try to really understand as to how does all this really come together based on personal values. And they can be different, of course, from person to person. The fifth M that we also look at, of course, which kind of ties this all together, is what we refer to as multi-complexity, which is how does all that then tie into their social structure, their social determinants of health, such as their financial structure, their revenue stream, such as their social network, such as their community, such as their residence, where they're living, communication with family or others. How does this really tie all together and really look at the patient not so much, again, as an individual with a list of medical problems, but so much as a human being, a person who deserves to be respected, a person who deserves the dignity which comes with this stage in life, and to really view them as someone who needs to be understood as opposed to simply looked at as a list of problems.
Wow, I think this is very important that all patients should have geriatricians as they continue to age. Based on everything that you're, covering with them, I think it's very important to, have all of these things assessed in someone's life and not just be looked at like, a medical patient and conditions and things. So why would you say it's important to consider all of these things together instead of one at a time?
It's very important to consider all of these things together as opposed to one at a time, because when we're looking at problems at one at a time, we're not getting the full picture. Each one of these issues may have an impact on another aspect of a patient's life. For example, if a patient may be on a medication, the medication may have a side effect. The side effect may have an impact on a patient's mobility or balance. If it impacts the patient's balance, they may not be able to necessarily go for walks or perform exercise or perform their daily activities of living. If they can't function at a level that they were able to previously, it can lead them to depress. It can cause them to lose their independence, and it can cause a cascade of a downward spiral, which of course then has detrimental health effects and impacts. So everything needs to be looked at as far as how does A tie to B, impact C, and then ultimately to conclusion D, and understand that all of this really ties together and can't be viewed in a vacuum.
Absolutely. And you can see how this could lead to patients feeling like their care is fragmented, like they might not be, solving everything that's, bothering them or, overall. You could see how this would be more all-encompassing. So now, who is responsible for putting all of these pieces together?
Yeah, that's a great question. And ideally, there would be a team of clinicians. When I refer to clinicians, I mean doctors, therapists, nurses, social workers, all working in tandem. And each visit would comprise one of these individuals in a stepwise process. That's not realistic. But ultimately, a geriatrician is best positioned to address most of these problems and to coordinate or refer, and then to circle back with patients to see how far they've progressed, what have they accomplished, what loose ends are there which we need to talk about or explore further.
Okay. And say once a patient starts to work with you, how much are you involved with their other physicians they might be dealing with? Do you work closely with them at all, or?
Yeah, so I'm absolutely involved with their other physicians. Depending on the patient, I may function as their so-called primary care physician, not at the same clip or pace of a traditional primary care physician. As I mentioned, I do spend significant amount of time with my patients. My initial visits are easily an hour, if not 90 minutes.
That's great.
And I frequently bring back my patients for a second visit to complete the total geriatric assessment. But absolutely, I am in touch with their physicians, and I sometimes seeing patients in consultation. They're being sent by their primary care physician for a more comprehensive assessment. And there are times where I will have subspecialists refer patients to me for assessments prior to medical procedures to perform a preoperative evaluation of the geriatric population and their patients. So I work both as a primary care geriatric physician. At the same time, I also do see patients in consultation.
Okay. And how frequently do you see your patients?
It really depends on the needs of the patient. There are some patients who I may see once every quarter. There are some patients who I will see once a month initially, depending on the nature of the problems or concerns that I may have, depending on the precise issue. For example, if the patient is someone who is cognitively intact, I would see them at a different frequency than a patient who's being brought in by a family member because of underlying dementia issues who may need to be reassessed on a more frequent basis.
Okay, that makes sense. Now, this is probably the biggest question people listening have. How do I know when it's time?
Yeah, great question. The best answer for that is there's a point in a person's life where things seem to have a perceptible change. The number of medical problems just seems to be piling up, and there are new problems. There are frequent visits to the emergency department. The list of medications just keeps on growing and growing. Something just doesn't seem right. You're not walking the same way you once were. You feel like you're slowing down. There's no hard and fast rule about when to see a geriatrician, but I think there's a point in a person's life where they feel that they're in a zone of transition, perhaps, and they realize that things are just not what they once were.
Gotcha. Okay. So what should someone bring for a geriatric appointment?
Yeah, a patient should bring to their geriatric appointments a list of medications. That's critically important. If they have any medical records from their previous primary care physician or hospital records, which I can't access through the RUMC electronic medical record system. If there's a caregiver or a family member who can come to the visit, that would be tremendously helpful as well. And that would be great to have those items at the first visit.
Okay. Do you find that most patients transition from GPs to you if they start seeing you, or do they still continue to see both?
Yeah, I find that most patients do transition, and I think they realize that the care that is being provided by myself as a geriatrician is what they're looking for. They're not just looking for a medical doctor. They're looking for someone who can understand them, who can listen to them, someone who has the time to listen to them. As I mentioned, we build into our appointments hour to an hour and a half slots just for the initial visit. Someone who can be empathetic, someone who has a listening ear, and is trying to really understand them, not, again, as a list of medical problems or a list of medications and dosages, but as a human being, as someone who deserves to be listened to, who deserves the respect of someone who's reached this milestone of coming to a geriatrician is a milestone in many ways and reflects a life that has been well-lived, hopefully, but someone who really needs the time and attention and who really wants that time and attention. And I'm more than happy to provide that in the context of the 5M assessment.
Perfect. That's wonderful. All doctors should have that approach. If they had the time, it would be wonderful. Okay, so I think this next piece really surprises people. Sometimes the issue isn't aging itself, it's the medications, like you said, right?
Yeah, absolutely. Many patients don't realize that medications do have side effects. We'll usually look at a medication and see that each medication has potentially 1,000 side effects, but don't realize that the more medications that we take, the increased chance there is for side effects to become more and more prominent. And frequently there can be a medical problem which is perceived to be a new medical problem, which in reality is a side effect of one of the medications.
Okay. And how common is it that medications are actually causing the problems for these older adults?
Very frequently. Medication side effects in the elderly is a very common problem. It's underappreciated, but it's a very common and very frequent concern. Again, because patients at this stage in life metabolize and break down and digest their medications differently. So studies which were done with the medications are usually not studies that included the geriatric or older population. So when they're being prescribed medications or taking medications for years, there are very few studies on many of these medications, including this population. So physicians are usually extrapolating results of studies in the younger population and assuming that those results are applicable to the older population. And that's not always the case.
Yeah, I could see that. I never knew that. Interesting. Okay. So can you explain what a prescribing cascade is?
Sure, a prescribing cascade is a classic problem in geriatric medicine. It's a problem in all of medicine, really, which is where a side effect of one medication is perceived to be a new medical problem. Because it's perceived to be a new medical problem, a new medication is prescribed for the new medical problem, which is really a side effect. Now, medication B has the potential to interact with drug A and create a new side effect complication, which is now perceived to be a new medical problem. And now medication C is prescribed to address side effect B, which was prescribed to address the side effect of drug A. And this, as the term implies, is really a cascade where one medication side effect leads to another prescription, to another side effect, to another medication, and suddenly you have medications literally raining down on the patient, all of which are avoidable and should not have been prescribed in the first place.
So what point is too many medications?
Yeah, great question. Depending on who you ask, in my opinion, any unnecessary medication is too many. Is there an arbitrary or objective number? We usually use 5 as a general number, but numbers in this context really don't have meaning. The question really is the medication necessary? Is the medical condition for which a patient is taking the medication still present? Is it still active? Is it historic but no longer relevant? And even if a patient is on a medication, can the dose be adjusted or reduced to reduce the likelihood of side effects?
Okay, and how often do you think that medication should be reviewed?
Medication should be reviewed at every major medical visit, after hospitalizations, after any particular change in a patient. So if a patient's presenting with a new problem, a medication review is mandatory. But really at any point of transition or change, and certainly annually, certainly far sooner in the geriatric population, the medication review is required.
Okay. So this might be the most important part of the whole conversation, what matters most. So what does that actually mean in real life for patients and families?
Yeah, great question. What matters most means what are the value systems that matter most to a patient at a particular point in time? What gives them fulfillment? What gives them joy? Why do they get up in the morning? And when they go back to their homes or their apartments and they're going to sleep and looking back at what they accomplished that day, will they have a sense of satisfaction, a sense of accomplishment, and will they feel that they had a reason to get up this morning? And they're happy about what they did that day. And that's based on personal value systems. It may be social value systems. For one person, it may be getting to the community center to play games or to just shoot the breeze with their friends. For someone else, it may be attending religious services. For another person, it may be spending time with family or grandchildren. It really depends on the person. There may be individuals who don't care about anything except enjoying life, and when their life ends, that's fine, and they just want to do whatever they want to do, as risky as it may be, and that's their personal value system. It really is a personal, individualized choice, and we try to understand that in the context of their medications and their general perspective on life.
Got it. Okay. So why is this such a central part of geriatric care?
It's important and really critical because this is a point in patients' lives where most people have essentially stopped working, they've accomplished things professionally, and this is a point where they're trying to perhaps do what gives them joy and satisfaction and fill in perhaps some of the gaps in their life. So this is something which we have to understand. Since they know that their lifespan is more limited at this point, obviously, and we want to make sure that their lives are as fulfilling and satisfying as possible. And that's very, very different. There are so many cultures on Staten Island, so many diverse religious groups, and each one may have a very, very different set of values. And we can't decide or determine that, our goal is just to keep the patients alive as long as possible if their quality of life or joy in life is diminished because of medication side effects, because of other things that we may do for them. So we have to understand them with the multi-complexities of every individual's life, how we can enhance their quality of life rather than do what we think we should do, is really do what they really want us to do in the context of their value system.
Yes, exactly. It's really personalized care, which is wonderful. So how would you say, maybe what's something that people wait too long possibly to address?
Yeah, people in general tend to wait too long to address those important conversations which are usually uncomfortable. what are the value systems of their elderly parents? Have they addressed estate planning, transferring of their finances or inheritance? Have they set or established a will? Have they taken care of prepaid for funeral expenses? You may say, why is a geriatrician talking about non-medical issues?
Yeah.
Because all of this can cause anxiety, can cause strife in families, can really lead to a diminishing quality of life among this patient population. But those hard conversations about values, about the future, about finances, about what to do in case mom or dad may lose the ability to make decisions, determining advanced care planning like healthcare proxies, all of the uncomfortable conversations, unfortunately, generally don't happen until it's an emergency.
And are you able to provide these patients with guidance about those subjects?
Yeah, I find part of my role as a geriatrician is to gently coax patients to have those conversations, to discuss these issues, to remind them of these issues. Some of them may not even be aware of what these issues are or that they exist. But for many patients, I find that my job, as I mentioned, is not just to focus on the medical issues, but to really understand their total life and put things in context. Everything impacts everything else in their lives. And these issues, although they may be viewed as more social type issues, in my opinion, are very important to touch, and they do impact healthcare decisions. They do impact decisions which need to be made if patients are hospitalized or need to be put on life support. And many of these topics, unfortunately, are sources of tremendous strife within families, among family members as well, if these are not addressed early on.
Absolutely. Okay. And if there was one myth about aging that you wish we could change, what would it be?
Yeah, one myth about aging is that there's nothing you can do about it. Everyone grows old. As I like to say, no one leaves this world standing up. So it's inevitable. It's going to happen. It's a natural process, and we can't stop it. And we can't do anything about it. And I think that myth, obviously not the one about leaving this world, but certainly about aging gracefully, aging as healthily as one can. We can do things. We can intervene to make that process as satisfying or as joyful as possible, and to really try to enhance quality of life to the extent that we can.
So I know you're launching this new geriatric program right here on Staten Island. So tell us what you're building.
Yeah, we're building a comprehensive geriatric program which is going to involve comprehensive geriatric assessments. It's going to involve discussions about quality of life, discussions about advanced care planning, discussions regarding community resources, social networks, isolation and loneliness in the elderly population. It really is designed to be as much of a comprehensive geriatric center and a center of excellence to ensure that we are not leaving any stone unturned in our assessment and evaluation to ensure that we can enhance and provide the highest quality of life within our ability for this population.
That's wonderful. So what services are now available through this program?
Yeah, through this program right now, we are providing, as I mentioned, the geriatric assessment, which comprises the classic 5M assessment. I'd like to add a 6th M for money or money discussions, estate planning, inheritance, things of that nature. Scams in the elderly is something which I educate my patients on as well. Critically important topic, and not enough, unfortunately, is discussed in the community or education setting for this patient population. We are also involved in assessing social support networks, trying to understand what we can do for patients, what resources are available on Staten Island, as well as New York City as a whole.
Great. Okay. And can you share a moment where geriatric care really changed an outcome?
Yeah, I've had patients who have come to me with a variety of issues, and one classic patient came to me with side effects, so clear side effects of a medication, and as I discussed this further, we talked about reducing the dose or even eliminating the dose to see what would happen, and as we discussed that, the patient realized that this was probably what the problem was, and after we were able to do that, the patient had achieved a higher quality of life and actually realized that the side effects were the problem.
With that, okay. So what would you say is the most rewarding part of what you do as a geriatrician?
The most rewarding part of what I do as a geriatrician really is seeing patients come in with a smile who are glad to come in and say, Doc, you're really helping me. I'm so glad I came to see you. You actually listened to me. You spent time with me. You treated me with respect. I didn't feel like I was rushed out of the office. And they say, you know what, you're the kind of doc I want, someone who will just listen, even if I can't necessarily change or have a reason to change anything, but I'm happy to listen to what their concerns are, understand their family dynamics, and really provide them a listening ear, as opposed to saying, well, how's your blood pressure, how's your heart failure, how's your other problems, and they really appreciate the fact that I'm there not just as a medical doctor, but in many, many ways almost like a guidance counselor, or in some ways almost like their friend.
Absolutely. I think that's so important. I think that makes you a gem of, a profession as a geriatrician. It's so critical. People want that to feel like they're being taken seriously, that you're taking the time for them. That most doctors, offices, they don't give that to you. You're, pumped in and out. So to have someone who's going to take the time to listen and genuinely care and put a plan together is most important. So that's great. So if someone listening takes one thing away, what should it be?
The next time you see a doctor, make sure your medications are reviewed. So critically important. If you're at a point in your life where anything which I may have said resonates, and you think you're at a point where you feel a geriatrician and a geriatric assessment is the right thing to do at this point, pay us a visit at 2655 Richmond Avenue. We're waiting for you with open arms and open ears. Wonderful. And we can't wait to have you coming through the doors.
Yes. Well, thank you so much for joining me today. It's been a pleasure learning all about all things geriatrics, and I would like to thank you once again.
It's my pleasure. Thank you for having me.
Thank you. So this is such an important conversation because aging is something we all go through, but very people are taught how to navigate it well, right? So if you're listening today and you're thinking about a parent, a loved one, or even yourself, this is really your reminder not to wait until there's a crisis, right? To take action now. So if you've noticed changes in memory, mobility, medications piling up, or just a sense that things are getting more complex, these are all signs that it might be time to see a geriatric specialist. And the biggest takeaway today is this: you don't have to figure this out alone. There are resources, specialists, and programs right here in our community designed to help people age with dignity, independence, and quality of life. So start the conversation, talk to your family, ask a doctor, and if needed, take that first step in connecting with a geriatrician. So Dr. Gottesman, thank you so much for being here and for the work that you're doing in our community. And if anyone would like to schedule an appointment with Dr. Gottesman at the New Springville Center for Family Health and Specialty Services, please call 718-818-5100 or visit richmondhealthnetwork.org. Thank you so much again.
It's my pleasure. Thank you.